bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Mental Health Problems in Youth with Developmental Disabilities, Foundations of Assessment and Intervention. And we have a great presentation today, but first I would like to recognize our newest knowledge translation partner. We're very proud to recognize the Children's Hospital Foundation of Saskatchewan as our newest supporter of our knowledge translation program here at CAFC. We haven't had a chance to incorporate them into the opening credits yet, along with our other partners, but we're very excited to have their support and wish them the best of luck as they help build the new children's hospital that's going to be located in Saskatoon, Saskatchewan, serving the entire province, of course. And they should be opening their new building in the next couple of years, so we wish them luck with that, and once again thank them for their support. All right, so it's my pleasure to welcome back a great panel to the CAFC Present stage today to continue our discussions on autism and other developmental disabilities. First, I'd like to welcome back Dr. Gail Andrew from the Glenrose Rehabilitation Hospital and the co-chair of the CINSER Research and Knowledge Translation Committee, CINSER being the Canadian Network of Child and Youth Rehabilitation, which is a network of CAFC members interested in improving the delivery of rehabilitation services to children and youth. And Dr. Andrew is joining me as my co-host for this session, as she does such a great job in connecting all the great research with the interests of the rehab community. And it's also my pleasure to welcome back Dr. Jonathan Weiss to the CAFC Presents stage. Dr. Weiss is an associate professor in the Department of Psychology at York University, and he's also a clinical psychologist. He holds the Federal Chair in Autism Spectrum Disorders Treatment and Care Research, and his research focuses on the prevention and treatment of mental health problems in people with autism spectrum disorder or intellectual disabilities. And Dr. Weiss is co-leading the H-Card project on youth and transition. And Dr. Weiss joined us a few months ago to talk about that H-Card project with a session that was titled Health of Young Adults with Developmental Disabilities Across Ontario, Results from the H-Card Program, where he and his colleagues brought some of the findings from that research project about how much of it was about how children with disabilities use the healthcare system and access the system differently than other children and families. And that, of course, is available on the Knowledge Exchange Network. So I encourage you to have take a search for that and have a look at that session as well, as it was very interesting. So it's my pleasure to once again pass the virtual podium over to Dr. Jonathan Weiss.
Thanks, Doug, and thank you again for the invitation to present at the webinar. I had such a great time a few months ago that you've got me to come back again, and this time with a different slant on a different presentation, still focused on health and in youth with developmental disabilities. But what I'm hoping to talk about over the next hour or so is the changing and evolving understanding of how we assess and treat mental health problems in youth with developmental disabilities. And I aim to interweave in this presentation clinical observations, videos of some examples of treatment provision that we've been involved in, and as well as research and kind of some of the science and the evolving conceptualization of what we mean by mental health problems in this population. When I'm talking about mental health problems in the context of developmental disability, I'm not referring to the developmental disability as the psychiatric issue per se. We're really trying to understand mental health and the emotional and behavioral problems that may lead to considerable impairment above a child's baseline levels of difficulties that might be related to having autism or an intellectual disability. When I'm referring to developmental disability or DD within this presentation, I'm really referring to youth diagnosed with either an autism spectrum disorder or an intellectual disability. I'm not going to talk over in this webinar about how to diagnose ASD or intellectual disability, but really more understand these emotional and behavioral difficulties within these youth. And what do we know about how we understand these problems and what we can do about it? And what are the rates even like in terms of, what do we know in terms of rates of mental health problems in this population? I hope that what I'm going to talk about here actually is informative for people who might not work directly with people with developmental disabilities as I define it, but more broadly to youth who struggle with chronic physical as well as cognitive difficulties, because I am a big proponent of the idea that we need to see the child and the family first and understand their unique context. So what's good for the goose is often good for the gander, so I hope that there's something in this for everybody. One of the things that's particularly challenging with understanding mental health in the context of developmental disability is to distinguish, in fact, the core symptoms of those developmental disabilities from internalizing or externalizing symptoms. Sometimes it's really, frankly, impossible to do in a confident way, to be 100% clear. If we look at some commonly used scales of psychopathology that we give to parents or teachers or youth self-report, like the Achenbach scales or the BASC or other things that people might commonly use to quickly assess or screen for levels of different types of internalizing and externalizing conditions. If you look at some of the actual items, you'll quickly see that some of those really load quite heavily on core symptoms of autism, for example, whether it be social withdrawal or atypical thinking. And so while many youth, for example, with ASD might have high scores on the atypical thoughts kind of dimension, it doesn't mean that they're having a psychotic episode. Far from it. It's reflecting the way that the questions are asked can reflect or kind of load onto that odd way of thinking that is part of ASD, but not the way that the scale was actually designed to, what it was really designed to reflect. So we have to be very cautious about reading sometimes too much into those kinds of questionnaires. And at the same time, we know that youth with developmental disabilities do struggle with emotional and behavioral problems. So disentangling those two is really important. In the literature, there's some debate about whether when somebody has both a developmental disability and a mental health problem, whether those combinations of symptoms reflect distinct disorders with distinct or unique causes, or whether they're co-occurring, coming from a shared etiology, so to speak, that's leading to different manifestations of impairment. And while this continues to be a source of important research, clinically many people are starting to refer to these problems as associated conditions because of the difficulty in disentangling whether in fact these are co-occurring, as I just highlighted, or really distinct. What seems to be very clear is that there's an association between having a developmental disability and higher rates of both internalizing and externalizing symptomatology. In Ontario, and this might be similar, but just to have a sense of the nomenclature, traditionally, when a person had both an intellectual disability, so not autism, but an intellectual disability and a co-occurring mental health problem, or sometimes even a significant challenging behavior that's clinically important, they were given the label dual diagnosis. In other parts of, in the United States, for example, dual diagnosis refers often to people with mental health problems and substance abuse issues, which in Ontario is described as a concurrent disorder. So just in terms of a bit of background, sometimes when people are referring to dual diagnosis, they are indeed referring to what I'm going to be talking about a lot today. I often encourage people to think beyond the idea of intellectual disability and co-occurring mental health problems to developmental disability more broadly and a co-occurring mental health condition. So I think we can include this kind of broader approach around ASD and what we're actually seeing, and as you'll see in a few slides from now, as a psychologist, I forgot to say, if I always feel like if I don't start off a presentation with some statistics, somebody's going to come and take away my license. So you'll see some of these rates coming up in a second. But what's very clear is that we need to recognize autism and a co-occurring mental health problem. They're so frequently occurring that sometimes it's the rule rather than the exception to the rule, depending on the context in which you're looking, the context in which you're serving families. That is, if you're working within a community setting or within a school board or within a primary healthcare setting, you're going to see different rates of these co-occurring conditions than if you're working within a tertiary level care center. So what are the rates like in terms of the prevalence of developmental disability and mental health problems? So a lot of the research I'm going to highlight to you comes from the United Kingdom, where they've done some excellent population level work across the countries in the United Kingdom to assess for, ascertain youth with intellectual disability and autism, and from that also in a more in-depth way quantify different types of potential associated conditions. So one by Emerson and Hatton, they capitalized on their typical census processes, but they have focused their census mechanisms on understanding the experience of people with intellectual disability and more recently autism in a more methodical way than we've done so far here in Canada, though with the CSD that is now available through StatsCan, we are starting to glean some of this information in our own borders as well. So one of the things that they looked at is a UK population study of 5 to 15-year-olds who had and did not have an intellectual disability. And broadly speaking, they looked at whether they met ICD criteria for an emotional disorder broadly speaking, an anxiety disorder, including a number of different dimensions of anxiety, what we describe as ADHD or conduct problems, as well as they looked at autism in addition to that. Within this population. And overall, those youth with intellectual disability were far more likely to have at least one psychiatric diagnosis compared to children growing up in the same, often environments, without a developmental intellectual disability. What's really interesting is, and I might digress here to say that why there were these higher rates, but we do see higher rates of just looking at any emotional problem or looking at anxiety specifically, behavior, certainly what they described of as oppositionality, whether that is similar to what we have. I think they still used kind of parent interviews to develop this information, so you have to take some of the labels with a grain of salt, but the pattern and the overall pattern of greater emotional problems and behavioral problems is quite clear. A more subtle evaluation of the experience of developmental disability and mental health came about a few years later by, again, a UK study by Vaso Totsika and her colleagues, where they used, again, census-level information in this study to look at 5-year-olds in the UK, and they used the Strength and Difficulties questionnaire, which is commonly used to screen for different rates of externalizing and some internalizing conditions, and I'm presenting you 3 of them that they used here. What was really interesting about their study was that they compared rates of problematic or clinically significant behavior, clinically significant problems across 4 groups, or between 4 groups. They had a typically developing comparison group of children in the UK. They had children that were identified with an ASD without an intellectual disability, children with an intellectual disability alone, and children with both an intellectual disability and ASD. And what you can see here, which is quite clear, is that, there's a few things to take away, is that between 10 and 20%, depending on the kind of problem you're looking at, whether it's emotional symptoms, which really reflected anxiety or sadness, or conduct problems or hyperactivity, between 1 in 10 and 1 in 5, typically developing youth, 5-year-olds, surpassed kind of this clinical cutoff for these kinds of problems. So mental health overall is a serious issue for children in general in this population. But we can look at the rates of what it's like for those youth with ASD who don't have an intellectual disability, and rates are far higher than their typically developing peers. And rates of having an intellectual disability alone without ASD are also much higher than the comparison group. There's little in terms of significant difference between those with ASD and those with intellectual disability. Although rates are different, the story is really that having a developmental disability increases your likelihood, even at a young age, of having these kinds of problems, and having both an ASD and an intellectual disability compounds the risk, essentially, of those more externalizing issues, which makes sense because a child identified at this early age with both of these conditions is often struggling more cognitively with managing these kind of stressors. And so it resonates with me that this, I risk to say, dually diagnosed group is even at greater risk than those with one of the two diagnoses. But the main story is that across both ASD and intellectual disability, we see these higher rates. So the same group then followed up looking at 5 to 16-year-olds. So now looking at a broader, much larger community study, and again, we see that same pattern around emotional problems and conduct problems that I just highlighted, but at higher rates across all the samples, whether it be typically developing youth who now 1 in 5 have emotional problems, clinically significant emotional problems, and higher rates across the board when it comes to, or an increasing relative to only the 5-year-olds in terms of the percentage that have it. And I mentioned before that sometimes it's the rule rather than the exception to the rule. And we can look at those youth with ASD here, where between 64% and 74%, depending on the scale they're looking at, would meet clinically significant criteria at this one moment in time. So here in Ontario, Doug mentioned the other study that I presented as part of another webinar. So I'm not going to go through this with a lot of detail, but just as a summary, we've looked at young adults 18 to 24 years of age, identified with ASD or identified with another developmental disability, compared to a non-developmental disability randomly selected group of young Ontarians and young adult Ontarians around many different issues involved with ISIS and administrative health data. And this is a large sample here, a large population-based kind of research where we had identified over 5,000 young adults with ASD, over 10,400 young adults with other developmental disability, and a large group of obviously Ontarians without developmental disability. And what you can see on the left-hand side of the graph is the rates of having at least one psychiatric disorder in addition to these other conditions. So 51% of these young adults here in Ontario have at least one additional psychiatric diagnosis in their administrative health data. 38% of those with other developmental disabilities have at least one additional psychiatric diagnosis. And again, about 1 in 5 typically developing young adults have a psychiatric diagnosis, at least one. So you can see here that rates do mirror in many respects with a pattern what was found in the UK. Okay, so enough of percentages. I think I've done that justice, and I've tried to convince you of these high rates. The rest of the talk is really going to be more clinical and conceptual in nature. Challenging behavior, is sometimes picked up within these clinical psychiatric kind of conditions or that I just talked about, but many times they're not. Many times behavioral problems in people with developmental disability are common causes of psychiatric referrals, both to, to community as well as hospital settings. It's the externalizing behaviors in particular, rather than the withdrawal or anhedonia, the amotivation, rather than internalizing aspects. Typically, it's the externalizing aspects that really start to get the ball rolling in terms of referrals and looking more into the questions of, is there an additional mental health problem at play? Sometimes, in fact, those challenging behaviors are indeed related to mental health, and sometimes they're not. It's important that we don't jump to considering that all manifestations of problematic behavior in people with developmental disability indeed reflect additional associated mental health issues or psychiatric issues. One of the reasons for this, and there are many reasons why this is problematic, but one is that if we do approach this that all behavior reflects a psychiatric condition, then we may be more likely to also consider the use of psychotropic medication to address those kinds of behaviors. And while there may be some evidence to show that some psychopharmacology can be helpful, there's additional growing evidence to indicate that we have to be very cautious about this. There have been some studies published, for example, with adults with intellectual disability and aggression, RCTs in the Lancet, a number of years ago now, that highlight that there's very little additional effect beyond placebo in double-blind controlled trials of some psychotropic medication to address aggression in this population. So we have to be very cautious, and typically psychotropic medication is not the first-line approach, but understanding the behavior as behavior and the functions of it really are where people recommend as the first line or first course of action. That being said, it can be a red flag and a hallmark of underlying emotional conditions, and we're going to try to I will try to walk you through this in a few slides. Another challenge in terms of understanding mental health problems in this population is particular, and I'll draw your attention to the challenges in understanding anxiety. I have to say, clinically, nearly always, in addition to some type of acting out behavior or externalizing kind of symptomatology, the number one problem that comes to me by families or by other clinicians, if they say, you do a lot of work in this area, can you meet this young person or talk with their family, can you provide us with a consultation? The problem says, inevitably has the word anxiety in there somewhere. And this is problematic or challenging for many reasons. So anxiety is more frequently occurring in people with developmental disability in terms of difficulty managing anxiety as an emotional problem. But within anxiety, when we think about anxiety disorders, I think it's really important that we consider the relationship between and how we distinguish between some aspects of anxiety with core symptomatology of ASD, specifically around obsessive compulsive disorder. And why is this important of trying to disentangle the two? Well, we know that in ASD there is this broader potential for rumination, for compulsive behavior, for fixations and intense or restricted interests. This is a hallmark of ASD. And this can overlap, at least if you're just looking at something on paper, when you ask somebody about obsessions. But I like to check in to see whether a person's obsessions is causing the anxiety, or is it the absence of being able to focus on obsessions that's causing the anxiety. That is, trying to discern the egosyntonic versus egodystonic nature of the obsession is really important to distinguishing OCD from ASD. And it's not to say that people with ASD can't also develop OCD. In fact, they're more likely to develop OCD because they already have this predilection for fixations, for obsession, for this intense focus. So it makes sense that if they were to manifest additional anxiety issues, that it might manifest as that trait essentially gone awry or kind of evolving into a maladaptive experience of something that was once syntonic is now something dystonic. You check in, do the obsessions bother the person, or is it the lack of, or the compulsions bother the person, or is it the prevention of accessing the compulsion that bothers the person? Not because, think about getting sick, that sometimes there's anxiety around getting sick as a result of germs, or is it a sensory issue with, for example, washing? Both from a behavioral perspective, if we were to look at that person, let's say that they don't have a good use of language, we see them washing a lot and needing to wash a lot. But you can quickly see how you go through two different aspects of treatment depending on whether you're understanding this as a obsessive compulsive disorder, where you're implementing a treatment of exposure with response prevention, or if this is a sensory interest, you might approach it in a different way of looking to shape that sensory interest and kind of reinforce incompatible behaviors, but in a positive behavioral approach. So how we understand this really does matter in terms of treatment provision. Understanding the excessive worry and generalized anxiety disorders is particularly challenging in people with developmental disability, because we're really depending on trying to access an internal frame of mind and where that worry becomes problematic. So if a person has difficulty communicating their internal experience, it can be very hard to actually understand the typical formulation of where generalized anxiety, as how we understand GAD. Social anxiety, many people with ASD have social anxiety, and distinguishing those symptoms is very difficult. And I would also encourage listeners to ask whether the anxiety really reflects what we mean by anxiety specifically, or is it really a tip of the iceberg, really reflecting more negative affectivity in general? That when we say anxiety, what we mean is feelings of anxiety, but we also mean feelings of sadness, or thoughts of hopelessness, or feelings of anger, or distress more generally. So really trying to be accurate with our understanding of the feelings and trying to understand that from a patient's perspective, I think is really important so that we don't have a broad brushstroke and put everything under the same category of anxiety. Aggression is very common in people with developmental disability, and that's very clear. There was a study done in Quebec a number of years ago now that surveyed service providers of adults with developmental disabilities. So this is about adults, not about youth, but it's something I want to share nonetheless. And they looked at rates of different types of verbal or motor behavior that was directed towards oneself, one's environment, or others, including different types. And they tried to quantify the percentage of these adults with developmental disability that demonstrated each one of these types. And you can just see here that rates are about, for most of them in terms of SIV or physical aggression or verbal aggression, between a quarter to 35%. Overall, about half of the service providers, when they reported on these individuals, displayed at least one form of aggressive behavior in the period of a year. That might not be too uncommon, even if we think about, that's a low bar to reach, at least one behavior in the period of 1 year. I think what's more important is to look at actually the severity of the behavior and the frequency of the behavior than it doesn't exist at least once. It's also important that we don't get too hung up on whether a person meets in my opinion, a very specific clinical cutoff. We have to reflect that this is probably a continuum of emotional difficulty that youth are struggling with. One study by Leifer actually looked at clinical and subclinical levels. And what you can see here on the slide is how in the brighter red is the rates of those youth who met with clinically significant levels on, they met enough criteria to qualify for major depression. For example, 10% of their 109 youth, 44% met for a specific phobia, 37% met for OCD, and then there is this more subtle group that they described of as having subclinical levels. And that's still an important group because those subclinical difficulties are still causing problems for those youth, often at school or at home or in their communities. So this is really, it's important that we think more dimensionally about these kinds of difficulties than in an all or nothing sort of way. I'll also draw your attention to this topic of suicide because it's often ignored in the developmental disability literature. It's only been recently, and more specifically around autism, that there's been a lot more attention on the topic of suicidality. So suicide attempts are more likely to occur in people with mild impairments than severe impairments, but it doesn't mean that it doesn't happen across the board. It's just that it's more likely when one has more kind of agency, essentially, to act on these kinds of feelings. Nearly half of all adults with developmental disability who are admitted to a psychiatric inpatient unit in Kingston, it was because of suicide ideation. So this is a very common occurrence within that tertiary level setting. And a recent review by Magali Segers, a graduate student here at York University, tried to quantify in the literature what existed around suicide ideation and behavior, and it looked at it was around 7 to 10% of people of adolescents with ASD, but that this was much higher in clinical samples, again, for adolescents specific with ASD at around 40%. So it is commonly occurring, at least ideation, and something that increasingly across the country, clinicians are trying to now develop tools to do a better job of inquiring about and understanding risk and strategies of reducing that risk. Overall, when we're talking about emotional and behavioral problems, another where the field is going to, and one thing that I've been very involved in, is shifting a focus from specific diagnostic labels to approaching this from a transdiagnostic perspective. That under many of these emotional behavioral problems, an argument can be made that there is a difficulty with emotion regulation, as an example. But anxiety is really a tip of the iceberg, a reflection of a broader set of internalizing and externalizing experiences. We know when we look at a number of different studies, usually correlational studies, that depression and anxiety are often moderately correlated with externalizing symptomatology in this population. We also know that there's a lot of overlap in terms of psychiatric diagnoses in this population. Many people with one psychiatric diagnosis who have developmental disability have more than one. Rates are about 1/3 of those with at least one psychiatric diagnosis have an additional psychiatric diagnosis. So there's a lot of overlap between different content, different types of emotional and behavioral problems occurring at the same time in the same person. And this kind of leads to this focus or an interest in negative affectivity more generally, and the what's underlying that. You know, if we think about emotional problems as the leaves on a tree, we can think of emotional regulation as the trunk of the tree, right? It leads to these different manifestations. This is also probably part of a transactional process that where mental health problems or emotional problems are related to that developmental disability symptomatology in a cycle or a transactional way. And I'll walk you through. This is the work that's been pioneered by Jeffrey Wood and Godot, his colleague Ken Godot. That they put it out specifically trying to understand anxiety and negative affectivity in youth with autism, but I think the same kind of message fits for people with developmental disability, broadly speaking. So here it goes. I'll try to walk you through their model very quickly. So they posit that that youth with ASD are going through their day-to-day life with a number of things that they describe as ASD-related stressors, and these ASD-related stressors come from, they suggest, 4 domains. This is part of ASD symptomatology in many ways. So going through their day-to-day with increased likelihood of social confusion or being in unpredictable social encounters, which can be stressful. Experiencing bullying and peer victimization, we know is more common in youth with ASD, or very common. Being prevented from accessing their preferred interests or those compulsions. Like if they go to school and they can't talk about plumbing all the time, or they can't flap and they really have this urge to flap or to do something, that can be quite aversive. And lastly, we know that there's a heightened experience of negative sensory sensitivities in people with ASD. So they suggest these are all different types of daily stressors that people with ASD are experiencing. And as they experience more of these, there's a cumulative effect that leads to greater mood dysregulation and anxiety. They suggest that when those stressors are more socially content-related, that you're more likely to see social anxiety. And then broadly speaking, they also feed into this negative affectivity more generally, particularly around other types of anxiety and depression. And when one increases with these emotional kind of consequences, you get some additional effects like increased social avoidance or increased levels of ASD symptomatology, greater repetitive behaviors, greater compulsions, greater decompensation of the skills one does have around social functioning. You can also get behavioral difficulties in acting out, especially in people who can't communicate their needs in other ways, and a reduced quality of life. And these kinds of effects then lead to greater levels of ASD-related stressors, and around we go. So this kind of dynamic between a person's vulnerabilities and their emotional state and the outcomes of that interaction and how that relates to stressors, I think, is very relevant to understanding the experience of youth who have a developmental disability and a mental health problem. There are some other challenges I'll highlight with assessments. One is trying to understand the rates of psychiatric disorders in this population, particularly in people who lack verbal skills to articulate their inner experience. There is some indication that people with developmental disability are more likely to have psychotic episodes than in the general population. This is particularly true, and clinically I've seen this often if you throw substance abuse in the mix as well. But that's not to say that we have to be very cautious, especially if a person can't describe that inner experience. And there was a study done a while ago looking at the rates of psychotic disorder in patients, adults with developmental disability in different kinds of hospitals, both in specialized dual diagnosis programs as well as people with developmental disability in non-specialized, more generic psychiatric programs. And those specialized programs had higher rates of mood and anxiety disorder and lower rates of psychotic disorder than what was found in the generic kind of programs. And one thing to consider in non-communicative or people with challenges with communication is whether aggression is being misinterpreted as a driver for the diagnosis of psychosis. And this relationship between interpreting aggression as a psychotic episode, as I mentioned before, can be particularly problematic to discern, but also in terms of how we aim to treat the problem. Last thing I was talking about that Reese and his colleagues have coined a term that they coined many, many years ago now, diagnostic overshadowing, is still something that is really relevant in this day and age in terms of calling our attention to. Diagnostic overshadowing is this reduced accuracy or reduced sensitivity in being able to identify mental health problems because a person has this additional diagnosis. And they suggest that there are three possible reasons why this is the case. That is, missing a mental health problem when one does exist. One is that the diagnosis or the category the issue is that they're seeing the mental health problem as ASD or as as intellectual disability. That's because he has autism, and so that's why he's acting that way. He's socially anxious, but that's autism. Right? So they're not really seeing it as social anxiety, they're seeing it as autism. A second is that they might acknowledge that social anxiety, as an example, does exist, but if you were to ask them to rate that, it's often depressed or reduced in terms of the actual assessment of the severity of that psychopathology, because it's almost like it's likely it's normal to have social anxiety if you have autism. So this is, it's there, but it's not as clinically important, it's not as significant. And lastly, it can impact even if there is the identification of the psychopathology, it can identify the way that it's being treated. So these are still, if you have autism, then CBT is not going to be helpful for you. So, or I can't do that, I can't work with you. So, which is not actually the case. We know that there are treatments that can be effective. So it's just about education, building that capacity to provide that kind of intervention. What's really important to address many of these challenges that I highlighted is recognizing the uniqueness of each person by figuring out what their baseline really is. This is best done, ideally done, when we have baseline information, when we have good assessments from an earlier period before emotional behavioral problems are quite prevalent, where we can make a kind of comparison. So if Jake what does Jake, for example, typically do? What's typical for a normal day and on their best day, his or her best day, in terms of their behaviors? What does that look like? There might be situations, again, where those same problems exist, those same difficulties exist as part of the developmental disability. And what's happening is that they've changed over time in severity, in frequency, in expression or symptomatology. So understanding what exists at the start and then how that's changed is really an important process. So not assuming that symptoms didn't exist at all and now they do, and not assuming that because they're there now it must have always been that way, but really understanding what changes occurred from what is typical in terms of the daily routine or interests or chores and activities. How has that changed from what that individual person can usually do? How is it different now? When were those changes first noted? Is it and understanding the timing of this? Has anything else happened over these times when we've seen these kinds of changes? So establishing a good baseline is really important. If we can't do it proactively, at least retrospectively through detailed interviews, trying to establish this baseline. Here's an example of a decision tree that's also very useful to use. This was coined by Elspeth Bradley, or adapted from Elspeth Bradley and others. Where they, looked at, okay, does a person, well, the take-home message here is really this, I'm not going to walk you through every single aspect, is to first, they suggest, try to rule out a primary medical problem as a source for what is being seen as potentially a mental health issue. Many people with ASD and intellectual disability have untreated or undertreated primary physical health conditions that can be impacting their emotional states as well as their overall mental health. Working within a psychiatric center in the past, a specialized program, or having a placement there, there was one young man with autism who came in with severe aggression and on many different psychotropic medication, and through a careful medical review, it was identified that he was severely constipated, and part of that may have even been because of the side effects of some of the medications he was taking. But nonetheless, the real issue was that by addressing that physical health issue, this young man who lacked the ability to communicate about his pain, that translated into a reduction in his aggression and other problems. And so not to say that he wasn't also struggling with other difficulties, but really ruling in or treating in a proper way that medical problem, whether it's dental care, whether it's seizure disorder, whether it's constipated gastrointestinal issues, is really important. Following that, to actually ask questions about the kinds of expectations and supports that are available for that person, and is there an alignment between the support, the expectations the person and their and care providers have for that person, and the supports that person's accessing in their communities. If I was going around with high expectations, or people were putting high expectations on me, and I wasn't given the kind of support that I needed to reach those goals, that might cause or lead to kind of emotional problems. But it doesn't mean that it means that the treatment really would be about adjusting those support and expectations rather than going down the line to saying this is an emotional problem that we need to support. And then there's this distinction, this subtle distinction between emotional problems and psychiatric disorder, where I think it's important that sometimes people are unhappy, they're anxious, and they deserve to get support for that before things develop into a full kind of a psychiatric condition in and of itself. And so there are ways to treat problems before they develop into psychiatric disorders. So the rest I'm just going to talk about a very brief review of interventions. And so I hope this brings some attention and maybe some things that people are interested in talking about more afterwards. So a brief review of what we know around interventions around mental health and developmental disability. A very brief review. So here we go. So for youth with autism who have IQs that are essentially in the average range or above, there's quite a few studies that have shown that cognitive behavior therapy and manualized CBT can reduce symptoms of anxiety. There have been a number of randomized controlled trials at this point of individual CBT, group CBT, CBT that involves parents heavily and others that don't, but so in many different manifestations. And so I'll talk a bit more about this. Overall, this is typically for people the studies involved youth 8 to 15 years of age. Usually the sessions are about 14 to 16 sessions long, but they can go as high as 32 sessions. And they don't always involve a specialized ASD CBT manual. Many times, many of the studies adapted manuals like Coping Cat and others that exist for treating anxiety in typically developing youth to the unique learning needs and behavioral profiles of people with ASD. So there is some adaptation, and then some of them actually develop their own versions of it, which essentially I've used, frankly, with people without ASD, with youth, and it's just as effective. So there's very little change other than, I think, the process or the delivery of the CBT. It's the same active ingredients for whatever those are. About 50 to 70% of the youth show considerable improvement, but we don't know very much about long-term maintenance of these gains. There's very, very little research to look at how have people who have made gains, how have youth who have made gains following CBT maintained those gains a year, 2 years, or even 3 years following treatment. And that's a particular concern for me in a clinical role. If I'm working with somebody in a short-term way, I'd like to develop help them develop those skills and those strategies so they don't have to come back again a few years from now. And we don't have good evidence yet, one way or the other, to really explain that part of the story. There's been a little bit of work to look at CBT for anger in youth with autism, just one study there, and one very small pilot published on emotion regulation skills, and this is something that we're very interested in here at York around applying cognitive behavior therapy for emotion regulation. For youth with ASD and who have also another intellectual disability, there's a lot of evidence around behavior therapy to address the behavioral manifestations of mental health issues, as well as mindfulness training. Though not a lot of research around mindfulness training, there is growing research, growing studies to indicate, in usually single subject designs, that point to the potential for mindfulness training to be helpful for those, for youth with ASD and an intellectual disability, with very modified versions of mindfulness training for both anxiety and aggression. Now, with these single subject designs, typically you have much longer term outcome measurement periods, which is encouraging. However, these kinds of interventions often require daily intervention, and so there's a considerable implementation cost to delivering them. But if you can deliver these kinds or access these kinds of supports and stay consistent with them, the potential for long-term gain has been far more demonstrated. But it involves a comprehensive way of supporting a person in terms of developing a new skill set. Mindfulness-based and positive psychology-based therapies have also been shown to be helpful for parents of youth with developmental disabilities. And in turn, there's some research to show that helping those parents indirectly has positive outcomes for the mental health of the youth with developmental disability. So sometimes it's about treating the family, and by treating the family, we're helping to support the child. Behavior therapy across the board, though, certainly for behavior problems, is a well-known and empirically supported way of approaching this, especially when one starts with a functional analysis of the behavior. So I think there's often an underutilized opportunity to capitalize on behavior therapists as well as speech-language pathologists to enhance the communicative abilities of people with developmental disability, and in turn working with allied health professionals to reduce the likelihood for additional psychiatric care or as part of a psychiatric team would be very useful. Here are a whole bunch of different published manuals if you're interested in seeing what CBT looks like for people with ASD. Facing Your Fears is one that Judy Raven published. Jeffrey Wood published an individual version of his child anxiety disorders family-based treatment, which is an individual treatment. Tony Atwood published a number of books exploring feelings. So you can see in the slide here, one's green and one's red. Really the only difference between these two books really is the word anxiety and the word anger and the color of the book, and I guess the kids on the front. But the actual toolbox, the tools that they teach are really essentially the same in both of these. And I think that goes to this interest in approaching things more transdiagnostically, that the same activities, the same tools that youth with ASD are finding helpful for their anxiety seem to be helpful for managing anger as well. In terms of adapting things, I really appreciate this kind of acronym, PRECISE, that Donahue coined, of what's needed. And really, this is something that is important for developing psychotherapeutic initiatives for any child, frankly, not just those with ASD or other developmental disabilities. You need a partnership here with fitting things at the person's right developmental level, whatever it is, and often that means bringing in visual cues and parents. And the rest here, I mean, as I hope you're looking at this in partnership, empathy, creativity, taking an investigative approach, and fostering self-discovery, making it enjoyable. This should be something that is important for every initiative when it comes to mental health for people with ASD. What I often feel like is when it comes to treating youth with developmental disability, that if you can find out ways of working and engaging with these youth around mental health, you can work with any youth essentially with those mental health problems. Now, yes, that's a broad kind of approach, but I think that one can inspire the other. And tools and skills that we develop working with youth with communicative difficulties and establishing rapport with children who struggle by definition with rapport building, often because relationships and social communication is at the heart of their difficulties, helps us better as clinicians to figure out ways to establish rapport generally. Parent involvement also seems to be key across the kinds of interventions that people are evaluating, whether it's CBT or mindfulness or behavior therapy. Many are heavily parent involved, and we even know that around ASD symptomatology, the parent-involved CBT appears to have stronger effects than traditional non-parent involved CBT, whereas if you do not have ASD symptomatology, there seems to be less of a moderated effect of involving parents. And there's a growing trend to see how even we can involve cognitive behavior therapy beyond the hospital or beyond the clinic, and especially into the school system for youth with ASD, providing a classroom-wide approach to managing anxiety because of how prevalent it is in this population. So there's lots of adaptations that I can go through. I think rapport building around treatment is really important in in any treatment, but especially for youth with developmental disabilities. And this can be hard when you're talking about people who might really just be stuck with their boundaries. And I think it's important that clinicians pick their battles. Often I'll do CBT, kids are on the floor, they're moving around the room. Sometimes they're bringing in electronics that they perseverate on for a while, and it's part of, you have to roll with it, essentially. The rigidity within ASD often makes this buy-in critical, because if they don't have it, it can really feel like pulling teeth, and that lack of rapport can really translate into poor treatment response. Ultimately, I approach, and I think it's important to approach all planning for treatments with the question, is what we're doing up here, and is it perceived to be logical? Is it perceived by the user to be fair? Does it make sense, right? Is it rational here? And how do you translate that into a language that fits with the developmental level of the client or the patient is really important. I want to briefly go through an example of CBT that we're evaluating for youth. I thought this might be interesting for youth who have ASD here at York University or finishing up an RCT related called the Secret Agent Society Operation Regulation. And this is something that was meant to build emotion regulation skills in children with ASD, and it was developed by Renee Beaumont from the University of Queensland, Australia, and she's been kind enough to let me evaluate it. I'm a big proponent of working with what exists if I can, rather than reinventing the wheel. So just briefly, SASOR is for 8 to 12-year-olds who have at least an IQ of 80 or above, and it's not meant to be for youth who have clinically significant necessarily levels of emotional problems, although we include youth who do have these kinds of difficulties. It's meant to build emotion regulation skills, which in turn we're studying if they translate into secondary outcomes around anxiety, mood, or behavioral problems that exist. And we've concluded a feasibility trial. I'm not going to try to convince you, I'm not trying to sell you on this product, but more to inspire you to see there are probably elements of this that are very common to the treatment kind of initiatives that we are already undertaking in our centers, or that we know are that are already undertaken in our communities. So this is a 10-week session. It's a very engaging, you can imagine with the name Secret Agent Society, it's a very engaging material because it's this spy-themed process that all the kids are cadets, that they have a cadet avatar as well that they go through these 10 sessions with, and everything's framed within this spy theme. So that really enhances some buy-in for this age group. Not with everybody, but it does really help, rather than, it's like CBT 3.0. It's taking what Phil Kendall did with Coping Cat and having this kind of visual to a new level. It involves a lot of homeschool relationship building, computer games, in vivo practice, as well as education with the parents, and a lot of positive reinforcement and praise. And parents are heavily involved in every session as co-therapists. We don't try to teach the parent how to work with their child, but we involve the parents in every step of the way, and that can be challenging at times, but we also find it has great benefit for that particular issue for youth with developmental disability, which is of generalization beyond the clinic setting. A few other kind of samples of what we do. So anybody who does CBT should be looking at this and realizing that there's not much different between this and what's typically done for anxiety specifically. But what we do here is that we're broadening it beyond anxiety to incorporate content. So this is our hierarchy, essentially, from mild to extreme situations that we want to help the child proceed into and manage successfully. But we want it to actually, to promote generalization, cross different emotional affect content areas. So things that might be boring or scaring or difficult, or things that they don't want to do but can't even find an emotion to go with it. So we just want it to be, in terms of its intensity, to be from mild to extreme, and then slowly through the 10 sessions, we try to develop those exposure practices where they can actually experience and find success in managing whatever emotion is coming up in those particular challenging situations. There's a lot of visuals that we use, and this is something that's inspired by all of the other successful CBT interventions for youth with developmental disability. There's a far greater emphasis on visual scaffolding of the concepts. For example, trying to teach them different types of tools after they're feeling distressed. So this is just an example. They use relaxation gadgets here, but every single CBT program has some aspect of additional visual support around the strategies that they're using. And that's what's really important of what I wanted to convey to you, is that adaptations are often required, but they can come in many different ways, and you can be very creative and do it in a way that works for you. We also have, just like every single CBT trial, a thermometer of some sort, a ranking system, a SUDS of some sort, where we get people to rank their experience from a scale of, in this example, 1 to 10, in this very visual and color dimensional kind of way. And we focus on anxiety or stress in one way and anger in another way. And what's good about this is that on the same form, we also put stickers around their situations, their body cues that they might be experiencing, and ways or relaxation things that they want to use. So all of this converges on the same visual support, which is a nice way of supporting somebody who might have memory difficulties or communication difficulties, so that they can see the whole content around the CBT about how behaviors relate to emotions, relate to situations, and relate to what we can do about it without having to just keep that all in their mind. But this is something that they can constantly look back to as a reminder. Here are those stickers I gave example to. So the body stickers we use, body clue stickers, things like clenched teeth or kicking things or shaking, right? Any type of CBT tries to understand the physical manifestations of the emotion, and this is very similar, trying to connect this for that awareness. Now, the last thing I want to share with you is I'm going to move beyond any CBT trial to think more broadly around mental health treatment within a broader system of care. And this is really informed by the work of positive youth development. So we've got less than 4 minutes left, and then I'll be wrapping up. So inspired by the work, I think that when it comes to mental health for any child, but certainly those with developmental disability, I think we need to also shift the conversation away from solely what I've actually spent the last 50 minutes talking about, which was on, frankly, mental health problems, to look at mental health promotion and problems on a continuum of what's needed. And I'm very inspired by this theoretical framework of positive youth development. I think every child, every youth deserves to experience this kind of development. So Lerner suggests that there are 2 key components to positive youth development. And if you think about this framework, it can really guide different types of interventions. So youth, to develop positively, youth need to come in with certain individual strengths. And those strengths are fostered in many different ways. Academic strengths, cognitive strengths, social strengths, physical strengths. Our experiences, our school systems, our families all feed into helping us develop those strengths, as well as our own intrinsic or internal capabilities. So it's not a static aspect. This is a developmental individual strength. And that has to be aligned with the ecological assets in our environments, those positive people, those institutional and physical resources that are needed, safe schools, access to timely resources, an ability to belong and to participate in our communities in a collective way. The opportunities to do so are really important for the alignment, the fit between the individual strengths that a child brings to those ecologies is really integral. And this is primarily something I draw attention to when I talk about mental health and developmental disability, because youth with developmental disability, by definition of the disability, may struggle more with this kind of alignment. Our worlds, our ecologies, are not necessarily designed or reflective to fit with the different kinds of strengths and challenges that a person with this kind of disability is bringing to these ecologies. So it's really important that we think about a person-first approach, but one that also looks at not only adapting and working on the person, but works on the environments, plural, to really make sure that that fit exists, because that's integral for every child. When you do have that alignment between the two, we seem to see greater growth in many different domains, whether it's a person's skill, their competence, whether it's their self-confidence, whether it's the connections they have with with others, whether it's their character or whether it's their experiences of empathy or demonstrations of empathy, all these very positive characteristics. And you'll notice that these are all C's. And I like to joke that if you can come up with another term that's a construct that starts with C, you can kind of add your name to this list. It's just a way that it's their way of kind of putting it through the 5 C's of positive youth development. And in fact, there are 6 C's that they suggest that when you have these kinds of positive developmental experiences, you end up contributing more to yourself in a positive way, to your family, to your society. And there's some of our work with youth with developmental disability, in fact, is showing that this kind of model, at least at a correlational level, so not in a directional way, does seem to play out for youth with developmental disability as well. And if you lack these kind of positive characteristics, you're more likely to have these internalizing and externalizing conditions. And those feed back into shaping your developmental strengths and your ecologies. So this kind of framework's, I think, very useful. And you can ask yourself, and you can ask people you work with, where do you fit in terms of supporting and addressing this model? Some people focus on the individual child, and their interventions are really focused on that developmental strengths. Others work in policy, work in health, work in broader systems of care, work with families, and they're really working on the ecology aspect of things. Some people are waiting until problems emerge, and they're kind of looking at that externalizing or internalizing component. So we all have a role to play somewhere in this kind of framework. The last thing I'll say is that a question that's kind of emerged in my mind that I'm putting out to others now is whether we really need even clinical interventions for mental health problems in this population. And you might think, well, on one hand, I'm kind of talking myself out of a job as a clinician, but that's kind of what I'd love to do. There's a little bit of work. It's interesting. There's one study came out relatively recently that I came across that was a randomized trial of providing structured CBT to a social recreation program for youth with ASD who had anxiety disorders. And what they actually found was that there were significant improvements in both groups, both those randomized to the CBT group as well as those to the social recreation program that was of the same kind of dosage, so to speak, the same structure, but had different activities. One was cognitive behavioral activities, and the other one was social recreation in nature. And this was both at short-term as well as at 6-month follow-up. So that kind of inspires me. It's not to say that that's the conclusion you should draw, but one that I think we have to question whether these kind of clinical interventions alone are really what's needed, or whether what we need is thinking about our community involvement as an intervention. Right? An example might be something like Special Olympics, which is a community program for youth with developmental disabilities that's often correlated, participation is often correlated with many positive constructs. And nobody would say, well, if you're developing an anxiety disorder, the first thing you should do is participate in Special Olympics. But within the broader framework of understanding mental health promotion and positive development, I think that these kinds of community resources are, in fact, aspects of intervention and critical to supporting the mental health of youth, some of the most vulnerable youth in our society. So I've kind of gone over my time a little bit, and I want to thank you for your attention today. I'm not sure if we have time for questions, but I look forward to that if it was possible. So thanks very much, everybody.
All right, thank you, Dr. Weiss, and we certainly do have an opportunity for some questions. We have a couple that have come in, and I'd certainly love to hear Dr. Andrews' comments as well. So that's just my reminder, everyone, to if you do have questions, type them into that question box, and we'll get them to Dr. Weiss to give a response. The first question that did come in was early on in the presentation when you were fulfilling your professional obligations to have some statistics at the beginning. I believe it was when you were you had the slides up talking about the prevalence of mental health disorders in children with autism spectrum disorder. And Julie was just asking if you would say, if you have any knowledge of whether these rates are higher than those with an FASD diagnosis, or are they similar to children with FASD or any other developmental disability? Is it different for autism than others, or do you have any? Has that even been looked at?
That's an excellent question. Typically, what I've seen in the literature is a comparison of, and this might be unfortunate, but a comparison of youth with ASD to youth with a heterogeneous group of youth with other developmental disabilities. So that's to say that most have not zoomed in on another homogeneous group. There has been some comparing, for example, autism to Down syndrome, or autism to Fragile X without autism. I can't personally recall of a study that's compared autism to FASD, but it would strike me that probably does exist. It's just not a one that I'm recalling right now. And what we do know around rates of associated conditions associated with FASD is that they're likely quite similar in terms of rates. That is, when you don't have a heterogeneous group of developmental disability, you'd likely see, especially for FASD, similar rates, at least in some dimensions of emotional behavioral problems.
Doug,
Andrew?
it's Gail. Could I respond to that question as well?
Yeah, absolutely. Being our resident expert in FASD, I thought you might have something to add to that.
Great. One of my colleagues at the University of Alberta, Dr. Jackie Pye, did a review of the literature 2011, and we currently have one of our graduate students doing her PhD in this area of looking at the comorbidity of mental health in FASD. And it's up to as high as 90% of individuals with FASD are also diagnosed with a mental health condition. And there's several reasons for that very high rate. One is the nature of alcohol-related brain damage. In the animal models, it's shown that it does alter the serotonergic system and some of the other neurotransmitters. But the other compounding factor in FASD, it's not just prenatal alcohol, is a risk for brain damage. A lot of the pregnancies are also associated with high level of maternal stress. And we know the whole stress response altering the hypothalamic pituitary cortisol axis of the mother will affect the developing fetus. That's been well shown by Dr. Joanne Weinberg and her group. So we have an additional stress factor on the brain development. And many of our children, unfortunately, are not well supported after birth. So we add a level of postnatal trauma, lack of appropriate developmental stimulation opportunities added to the developing brain that may affect attachment and be reflected in, as they get older, mental health conditions. So it's a dilemma whether it's the alcohol causing the situation of the mental health condition or it's this cumulative effect of multiple factors. So I think we have a lot of research that needs to be done in this particular area. And so much of the intervention in FASD takes into consideration both the brain damage, but also dealing with mental health issues and the trauma issues. So it's not an easy answer, but it's very high, at least 90% comorbidity.
Thank you very much. The next question that came in was from Milena, and she's asking, in the non-ASD population specifically, how does clinically diagnosed OCD look in persons with developmental disabilities? She's just saying, any thoughts from your experience are welcome.
So again, it's kind of a broad heterogeneous group, developmental disabilities. So in many ways, it depends on the person's individual the etiologies can often interact with the etiology of the developmental disability, but I think that there can be some pathoplasticity, so to speak, in terms of the expression depending on the level of developmental disability. That is the level, what I mean by that is the level of intellectual impairment and a level of impairment in adaptive behavior that may also be associated in terms of sometimes the content of the or the way that the obsessive compulsive kind of relationship emerges or is expressed. But it's clear that it still can develop and still can kind of affect a person in the same way, even if you have an intellectual disability, so to speak, without autism, just an intellectual disability, that they're more likely to develop obsessive compulsive disorder as than in the general population.
I was just saying, Timothy's question is he's asking if you can offer any clinical pearls to flesh out a depressive or bipolar disorder in a nonverbal autistic child.
Okay, so this goes back to that whole idea of understanding a child's baseline to begin with. What's typical for that child in terms of their behaviors, their engagement with others, their engagement in their preferred interests or activities, or their level of behavior, essentially. What is typical for that child on a general day and on a really good day? What are they typically like, and when has that changed? How has it changed, and how long has it changed for? I think are really important questions to understand, at least to get it. It's hard to at least to to start to get at whether there are these kind of changes and whether those changes can be accounted for by changes in the environment or not, I think are really important. So for example, as I don't know, every child's different, but if there's a child who typically is nonverbal and demonstrates a lot of repetitive motor mannerisms, is flapping a lot, is kind of typically quite energized and quite energized, and then there's been a sudden or a very noticeable change from that kind of energetic state, and this is maintained over time, and one really can't account for this by changes from a good medical workup or by changes in their environment, what's happened around them. Then when we start to put things together of how things have changed from that child's baseline, from what we typically have seen from that child, I think that's where you have to start with trying to understand, is this child experiencing some aspect of depression or some aspect of a depression with a manic experience as well. But I think it's very important just to say that before that also, you also have to ask the question of whether we see these behaviors or the changes in behaviors, and whether we can explain those changes in behaviors, not only as a result of changes in the environment, but in terms of our understanding of the functions of that change, right? Whether there are consequences to those changes that are shaping those kinds of changes in behavior.
The other half of his question was also, he was asking if you can comment on sleep disorders in children with ASD, especially those with moderate to severe ID.
Right, so there's actually, I'm going to kind of refer that question out to say that there's work being done through NeuroDevNet, specifically around sleep disorders for youth with neurodevelopmental conditions. Penny Corcoran and others from other researchers are involved in NeuroDevNet to look specifically at sleep for this issue, so they could speak more specifically to sleep disorders. It definitely is kind of an issue around ASD, dysregulated sleep, and how to support that with both good sleep hygiene, parent support, as well as questions around the role of certain medications to help. But it seems to be very common for youth with neurodevelopmental conditions, broadly speaking, and youth with ASD specifically. But I can't tell you about a specific rate myself.
Doug, the Autism Treatment Network from Autism Speaks, here at the Glen Rose Rehabilitation Hospital, we're one of the 2 Canadian sites. There is an active sleep group as part of the ATN, and they've published some nice algorithms of how to approach sleep difficulties in children with ASD. So I think that could be readily available online through Autism Treatment Network, ATN.
Yeah, that would be thanks very much, Gail. That's a great resource for everyone to have. And in fact, as Dr. Weiss was saying, Penny Corcoran, lead researcher in the Better Nights, Better Days research program through CIHR, her and members of her team actually, in fact, did a presentation. We've got it up on the screen there, so you can actually access all of that information. They don't have a lot of information at this point on the sleep issues in children with disabilities. As Jonathan was saying, it's work that they're just starting now, and should have some results, I think, in the fall is when they mentioned it briefly on the presentation that we did with them a while ago. But Dr. Corcoran and Dr. Shelley Weiss are both going to be joining us at the CAFC annual conference in Halifax in October. So if you're interested in hearing more about that there, then please don't hesitate to register for a conference, and you have a chance to talk with them specifically about that. So, Dr. Andrew, do you have any thoughts, any comments? We'll give people an opportunity to type in a few more questions. We are just about out of time. We have about 10 minutes left, but I did want to get your thoughts and comments on the session so far.
As somebody who works across Pan disabilities, I was actually substituting various other neurodevelopmental disabilities every time Jonathan said the word autism. And everything that he said is fully applicable across all disability populations. One particular group that we tend to forget about are children with neuromotor disabilities, our children with cerebral palsy, spina bifida, and so on. And I think a lot of the primary health care providers don't even ask about how the kids are feeling and doing. And the model was published just this year through Canadian Pediatric Society in a position statement about mental health problems in children with neurodevelopmental disabilities. It was in the March issue of Pediatric and Child Health. And the model uses exactly what Jonathan described, a child world interactional model based on the International Classification of Function, and looking at the child and how their environment impacts how they are feeling and reacting, along with their basic brain issues. And the other piece was the caregiver stress and the caregiver burden as part of the interaction. So maybe as we plan future webinars, to ask the primary author of this paper, Dr. Klein, if he would like to do a session on mental health in the neuromotor disability population.
It's a great suggestion. I'm sure there will be lots of interest from this community in that topic, for sure.
I'd also jump in to say, and thank you, Gail, for bringing that up, that I completely agree. You know, the story that's kind of shown through this research and what I'm trying to convey is exactly that this should not be autism specific, but that many of the lessons learned really are transdiagnostic in nature, that we can carry forward to whether or not it's specific, to take away that siloed approach to this is only about autism. Even if the research was about youth with autism, the messages, the principles behind it are really critical across neurodevelopmental conditions.
Exactly. We don't have to, as you said before, reinvent the wheel. We can borrow from what other people have done, apply it to our particular population of interest, and there might be some tweaking that needs to be done, but I think the core principles are the same.
All right, we did have another question come in from the audience, just suggesting that admission to hospital can be a challenging time for a child with a developmental disability. What tips and strategies can be used to ease that transition?
Again, I think this is something that's probably done across conditions, and there could be a lot of lessons that are shared. But there has been actually quite a bit of work trying to understand the experience of youth with people with intellectual disability and those with autism, especially within the emergency department, but more broadly, accessing and being admitted to hospital in terms of how clinicians kind of first identify and ascertain kind of the process. There's been work done at Sick Kids. There's being work done perhaps even at the Glenrose. Gail can kind of jump in on that. So there, and then with adults with ASD at Sunnybrook, with developmental disability at Sunnybrook and others, and the whole H-card program that Doug had mentioned before has a stream that is actually focused on developing and working with hospitals around tools to support patients with developmental disability, not in terms of how one assesses for medical problems, but exactly what the question was about, which is on how do you interact with and create an environment that is friendly to that and is aligned with the needs of that person, that patient, so that you don't complicate or continue to create more aggravation or more problems. So, for example, a few of the broad stroke lessons that the content is going to look different, but that seem to be very important. One is that there's some type of identification system up front for that medical professional and that hospital to be able to flag that this person has a developmental disability of some sort, or to be more specific, but that flagging happens once and can be shared among the health professionals that are going to be interacting with that patient in that setting, so it doesn't keep getting revisited or that it's not missed after it was shared. Second is that it seems to be very useful to have an additional pathway to access if a person is identified with a developmental disability, in terms of trying to ensure that the timeline towards admission and towards the kind of inpatient process can be quickened, and that there can be a place that supports the person's sensory sensitivities and their communication difficulties. So any of those kind of supports, but it's not one that necessarily has to be in every single place all the time, but set a kind of a pathway to care that is triggered when there is this kind of ascertainment or identification at the front end the first time. That's, of course, if this is a sudden process. If if a person if we know in advance that a person with a developmental disability is going to be admitted to hospital, then really taking the time to understand the unique patient's needs in advance, helping to prepare them through different types of visual means to be ready for what this experience is going to be like, even going to visit the hospital in advance of that admission, for example, to get a sense. So it really depends on the context of the admission, but some of these kinds of stories seem to be emerging regardless of whether you're trying to support youth or adults with developmental disability. These are kind of the principles, or many of them, that seem to be important. But there is a lot of content specific that is being generated across the country, both through HCARD and through other initiatives.
All right, thank you very much. And I think with that, we're just about out of time. I'll just hand it over to the podium over to Dr. Andrew one more time. Just just before we wrap up, is there any other thoughts you'd like to bring on this session?
Just picking up from Jonathan's last comments, I think the importance of information sharing and educating all individuals within the healthcare field about dealing with neurodevelopmental disabilities. That's one of the strategies we've used here at the Glenrose. We have an active training relationship with our acute care colleagues at the Stollery Children's Hospital so that they are more autism informed. The other piece I'd like to mention is the transition of youth with neurodevelopmental disabilities into the adult world. We have a lot more work to do into the adult healthcare world, helping those providers understand neurodevelopmental disabilities, because most of the mental health services, and I'm more familiar with what happens when my patients with Autism Spectrum Disorder transition, the adult system of mental health care does not support them. We have 2 psychiatrists here in our community who are experts in intellectual disabilities, but 2 is not sufficient to meet the need. So again, more work to do.
Thank you very much, Gail. And for the final word, we'll hand the podium back over to you, Dr. Jonathan Weiss, for any key messages or thoughts you want to leave the audience with before we sign off.
Thanks. I think I completely agree, Gail, with what you just mentioned. And in terms of kind of my last message to the audience is that regardless of whether you're a specialist working with developmental disability or neurodevelopmental conditions or not, we have, especially if you're not, you still have the skill sets that can be adapted to support often the mental health or the healthcare of youth with developmental disabilities and of their families. That these are children and developing individuals first who have these unique profiles, but many times it's a coordinated approach from specialized to generic care that we can provide, and that is most important within this notion of community inclusion, and so we all can have a role to play, and it's about figuring out how do we adapt and build on our unique skill sets already and our training already to support people who have these unique profiles. So we all have a lot of potential to be involved.
All right, thank you very much. And where would be the best place for people to find more information about this topic, about the other work you're doing? We had the ASD mental health blog up at one point. Where's the best place that people can go to find more information?
Right. So around ASD and mental health, as part of the chair in ASD treatment and care research, we did launch this ASD mental health blog where we try to feature, as part of that mandate, summaries of research on mental health and ASD. And we've got over 50 lay summaries right now. It's constantly being added to, so there's a lot of a wealth of information there on that topic specifically. I'd also direct you to, as Gail mentioned, the ATN, the Autism Treatment Network, and more broadly to the work that's being pushed out by Autism Speaks and NeuroDevNet.
All right. Thank you very much. And with that, I think we're going to wrap up. Great presentation, lots of great information and resources that people are certainly going to take away and digest. And Dr. Weiss's contact information is available on all those websites if you do want to follow up with him, of course. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live as you get to participate in these discussions. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network. And we did have a number of questions about access to the slides, etc. We will be sharing the slides and the recording. We will be removing the video clips that Dr. Weiss had shown, but the rest of the presentation and the slides will be available in a couple of days. We usually get them up by Friday so that will be available to you, and you will receive a notification from the system when that's available. Next week, it'll be the last episode before a little bit of a break over the summer, but we're going to hear a very interesting story about how a children's hospital sought to be the plaintiff in a lawsuit to challenge the validity of gene patents for a potentially deadly condition. The result was an agreement to provide the Children's Hospital of Eastern Ontario and all other Canadian public sector hospitals and laboratories the right to test Canadians for long QT syndrome on a not-for-profit basis. The session is going to be titled Going Rogue, How a Canadian Children's Hospital Challenged Gene Patents, and we're going to be welcoming Dr. Gail Graham, Nathaniel Lipkiss, Dr. Julie Richer, and Dr. Olga Jaranova to discuss the groundbreaking case that has defined the pathway for all public Canadian hospitals and labs to conduct gene testing without the legal roadblocks from gene patents. So that's going to be a really interesting story. We hope you'll join us for that one next week. And then we'll be taking a bit of a hiatus for about 3 weeks over the summer, but we'll be back on August 10th with Dr. Durhane Wong Rieger of CORD, the Canadian Organization for Rare Disorders, to talk about some of their work and some interesting research in the area of rare disorders. So a great session coming up next week. We will be taking a bit of a hiatus, but thanks again for joining us today. We hope you enjoy your summer, and we hope to see you back here in a few weeks. Bye.